Welcome to another episode of CLOT Conversations from Thrombosis Canada. I'm David Airdrie, Executive Director.
I'm Jamil Abdulrahman, hematologist from Toronto General Hospital.
We're here to provide you with updates on diagnosis and management of thrombosis, featuring interviews with authors of recent research publications and highlights of education programs from Thrombosis Canada. Thank you for joining us for this episode.
In this episode, we'll be discussing a recent paper published in The Lancet entitled Intermediate Dose versus Low Dose Low Molecular Heparin in Pregnant and Postpartum Women with a History of Venous Thromboembolism, the Highlow study, with co-authors Dr. Saskia Middeldorp and Dr. Hanke Wiegers. Dr. Saskia Middeldorp is a professor of medicine and head of the Department of Internal Medicine at the Radboud University Medical Center in Nijmegen, the Netherlands. Prior to her transfer to Nijmegen in January 2021, she had been a professor of medicine at Amsterdam University Medical Center for over 10 years, leading the clinical thrombosis and hemostasis research lines of the Department of Vascular Medicine. Since January 2023, Dr. Middeldorp is one of the 4 research domain leaders in the Radboud Research Institution for Medical Innovation. Her present research focuses on several aspects of hereditary and acquired thrombophilia, women's issues in thrombosis and hemostasis, and the clinical evaluation of new anticoagulants and antidotes. And Dr. Hanke Wiegers is an MD PhD student at the Department of Vascular Medicine at the Amsterdam UMC, location AMC. In June 2019, she started her PhD trajectory under the supervision of Professor Dr. Saskia Middeldorp as supervisor and focuses particularly on women and thrombosis. On the 17th of March 2023, she will defend her PhD thesis entitled Progress in Prevention and Prediction of Venous Thromboembolism in Women, focus on pregnancy and the postpartum period. Dr. Hanke Wiegers started as a gynecologist in training on the 1st of January 2023. Thank you for participating in our podcast today.
It's great to have you both on board. And I'm going to start by asking, can you give us some background on the risk of VTE in pregnancy in the antepartum and postpartum period?
Yeah, so I think, first of all, it's a great pleasure to be here in this podcast. And I hope that people in Canada and outside of Canada will enjoy listening to this. And the risk of thrombosis in pregnancy and the postpartum period in general is about 1 to 2 per 1,000 pregnancies, which does not seem very high. But on the other hand, the impact of having a clot in pregnancy is quite high. Thrombosis very often occurs in the iliac veins and the pelvic veins, meaning that women have a much higher risk of post-thrombotic syndrome. And clearly the use of anticoagulants during pregnancy, but also around delivery is coming with a lot of, trouble. And I think very importantly, and that is what our study was about, was women who have a history of VTE, and they have an estimated risk of recurrence during pregnancy and postpartum period somewhere between 6 to 10%. And that was basically the reason why we felt this unmet medical need.
So how is anticoagulation different in pregnancy compared to non-pregnant individuals? And how was thromboprophylaxis managed in pregnant women with prior VTE before this study?
So it's different. The use of anticoagulants obviously is different because there are 2 patients. There's a baby on board, and you have to realize that many all oral anticoagulants cross the placenta and are either damaging or teratogenic to the fetus or are actually anticoagulating the fetus. And that is why we have to rely on heparin, which has to be administered subcutaneously. And nowadays, it's low molecular weight heparin that we use. And basically, the vast majority of women with a history of VTE do require both antepartum and postpartum prophylaxis. And there's a small group of women who have had a transient risk factor associated with their previous clot. And not hormonally provoked, that can only rely on postpartum thrombosis prophylaxis. So that hasn't changed because of this study. We followed the guidelines in terms of women who were eligible for antepartum and postpartum prophylaxis. But what we didn't know was what the right dose is. And that is the main rationale for the Highlow study. So just imagine that we use doses that are different between hospitals and between protocols because nobody knows. And we also know that in pregnancy, these women are generally young, have fantastic renal function. They have an increased circulatory volume, and they gain weight during pregnancy. And we are giving them doses, if you use the low dose prophylaxis, that are basically tested in elderly patients who are undergoing knee or hips surgery. And I, in my clinical practice, had observed quite a few recurrences despite the use of low dose and prophylaxis. And that was basically the big driver of setting up the Highlow study, to see whether a higher dose is necessary to prevent antepartum and postpartum recurrences.
Okay, great. So let's talk a bit more about the study. So you conducted an investigator-initiated open-label RCT at 70 centers across the world. Who did you include in the study, and what interventions were the women randomized to?
Maybe Hanke.
Yeah, sorry, could you repeat the last question again?
No problem. So you conducted an investigator-initiated open-label RCT at 70 centers across the world. Who did you include in the study, and what interventions were the women randomized to?
So we included women, as Saskia already said, with a history of venous thromboembolism, and the majority of those women were provoked by hormonal contraceptives, or they were unprovoked. And so that was the majority of the patients who were included.
So the intervention consisted of an intermediate dose of low molecular weight heparin, and the comparator was the routine prophylactic dose that we use in clinical practice. And the intermediate dose was roughly half a therapeutic dose. And the other thing that we did was we increased the dose according to increasing weight during pregnancy, which was different from the low dose, which was fixed from the beginning and remained the same over pregnancy.
Okay, great. So what were your findings regarding the VTE outcomes?
So if we look to the primary outcome, so that was from the start of the pregnancy up to 6 weeks postpartum, there was no differences in between the low dose and the intermediate dose in the recurrences of venous thromboembolism.
Okay. And then how about the bleeding outcomes?
So if we look to the both doses, so the intermediate versus the low dose, we did not see any difference. So in both groups, we saw 4% of major bleeding in both groups. So that was the main outcome of the safety outcome, so major bleeding.
Okay. And then you also conducted a post hoc analysis looking if there was a difference in treatment effect in the antepartum versus the postpartum. Can you tell us a bit about that?
So yeah, it was a post hoc analysis since it was not predefined in the statistical analysis plan, but we looked to the absolute number of events. And then we saw, when we looked to the antepartum period, that the number of events was similar for the intermediate versus the low dose group. But when we looked to the postpartum period, there was differences. There was a big difference between events in the intermediate versus the low dose group. So we saw more events in the low dose group compared to the intermediate dose group. So that was very interesting.
And perhaps if I can add to that,
yes,
for background. So overall, there was in the primary outcome, there was no significant difference. It was 2% and 2.9% for recurrent VTE. And this whole observation about the let's say differential effect postpartum came as a surprise, and unfortunately, of course, we didn't put that down in a statistical analysis plan, but it may make sense because potentially the prothrombotic risk the thrombotic risk is higher postpartum than antepartum, meaning that perhaps you just only need a higher dose postpartum. And obviously, this was against our hypothesis. We had hypothesized that overall, the intermediate dose would be superior in terms of efficacy. So running this trial with over 1,100 women in so many centers was, if you look back at it, let's say, a little bit of a naive start. It took us many, many years to complete. But I think it taught us a lot, not only intervention-wise, but also, I think, in looking at differentials between antepartum and postpartum risks and how you mitigate that risk by different doses. But we should also be a little bit modest. It was a post hoc analysis. And ideally, of course, we would like to confirm this in future studies.
And I think there was a difference in the type of VTE as well. Was there not between the two arms? Can you tell us a bit about that?
Yes, that is correct. So there was a difference that was in pulmonary embolism. And that benefit in the intermediate dose actually even was statistically significant, but it was all limited to the period after delivery. In fact, we have a negative study, but there were so many interesting observations. The numerical recurrence rate was really, really similar between the arms antepartum, but postpartum there were striking differences. And there was also in the secondary endpoints a striking difference in the number of superficial vein thromboses. And we actually believe that, we didn't put that in our primary endpoint, but I think it's a very patient-relevant outcome because women who have a superficial vein thrombosis, despite prophylaxis, usually have to increase their dose of low molecular weight heparin, even though there is heterogeneity, what doctors do, but it's a very important outcome for women. And this was also very, very different in the postpartum period.
Right, okay. So before this study, there were only 2 small RCTs looking at thromboprophylaxis in pregnant women with a history of VTE. Why do you think there's such limited data in this demographic?
Yeah, so these 2 small RCTs are old. One of them was 16 patients and the other 40 patients. So 40 and 16, which is a total of 56. Maybe, Hanke, you can tell us a little bit about how complicated it was to run this study, just to understand that, we had to have some stamina here. And apparently it was too difficult until now. But Hanke, maybe you have been seeing so many of these patients.
Yeah, so patients of course, patients were screened during outpatient clinic visits, for example, when they were visiting the outpatient clinic from Professor Middeldorp. And they were informed about the study, but also, for example, about the risks of bleeding. So we didn't know whether an intermediate dose was also increasing the risk of bleeding, especially peripartum. So that was something which we did not know yet. And also the access to neuraxial anesthesia, because the time interval for the intermediate dose was longer, 24 hours, compared to the low dose molecular weight heparin group. So that was a time interval of 12 hours. So when patients were randomized, because it was a randomized controlled trial, to the intermediate dose, they were aware of the fact that they did not get access to neuraxial anesthesia. And also the bleeding risk was also something which we took into account, or which they had to take into account. And sometimes they were feared to want to participate into the trial. So that was something which was sometimes very hard.
Yeah, and also I think this patient population in particular is very often excluded from trials, and I think that, as I said, if you look at the rationale where we actually extrapolate from elderly patients to a group of otherwise healthy young women who are now pregnant, it has to do with let's say, I think, legal issues, ethical considerations, and we shouldn't always also forget that there were also colleagues of us who were having a strong conviction about what the right dose would be. And I think that also influences how you counsel women. So getting these 70 centers together and doing this, we started and we said, let's see, perhaps 1,000 women are needed. But it took us many years, and I'm very happy and very proud of the team spirit that we had amongst all the investigators and all these women to get this done. And one of the things indeed is the neuraxial anesthesia. There are massive heterogeneous practices around the globe in how pregnancies are dealt with, how women get their babies. We are from Holland, where we still have our babies. Some of the women, including myself, have babies at home. If you compare that, I'm sure, to the practice in Canada or in the US, it's very different. So it's good that this was an international study, but it also illustrated the challenges in conducting an RCT. And I think that is the reason why it hadn't been done before.
Yeah, maybe it's nice to know that the first patient was included in April 2013.
Oh, wow.
So it took a while to complete the study. So almost 10 years of recruiting patients. So yeah, that's
that's incredible. And so what do you think the takeaway points are from the study, and how should we be managing thromboprophylaxis in pregnant women with a history of VTE in the antepartum and postpartum periods?
Yeah, so regardless of when they had their VTE and during which circumstances, if they are eligible to antepartum and postpartum prophylaxis according to the current guidelines, those women, my take-home message is they are okay with low-dose antepartum prophylaxis, which is great because it gives them access to neuraxial anesthesia in many instances. But postpartum, I would suggest giving intermediate dose. One disclaimer is, of course, we are academically biased because we did this study. I think the data are very strong, and I'm really looking forward to see how the evidence will be rated for this particular differential approach in antepartum versus postpartum in, for instance, the update of the American Society of Hematology guidelines. I'm a panelist there, and the panel is, the chair is Professor Shannon Bates from Hamilton, Canada. I probably have to refrain from voting on everything. So yeah, I think this will be difficult because it was a post hoc analysis. But for me, that is my take-home message.
And I think maybe to add, Saskia, is also a take-home message from this study in general. So including pregnant women in trials is that the fear of including women in the past, I think we proved that you can do trials in women and pregnant women. So continue performing clinical trials in women and pregnant women. It can be done and it must be done.
I love that addition.
So is there anything that we haven't discussed today that you'd like to add?
Maybe I would like to add one other thing. And that is the fact that in our Highlow study, which was a randomized controlled trial, as being said, so it was very prospective with protocols in place. We already mentioned that there was heterogeneity in terms of treatments prior to the study, but this also occurred during the study. And so we had quite a few protocol violations. And one of the things that we learned is that some of these, what we call protocol violations, were also women who stopped prematurely postpartum with their low molecular weight heparin. And I think that is because of the burden of treatment. And there may be a slight advantage also for the low dose. But on the other hand, postpartum, the risk is highest. And it could very well be that we shouldn't only be studying doses, but we should also study how to further improve adherence, because that might have had an effect on our intention to treat analysis. And with that, I think it's really great that right now, for instance, Dr. Leslie Skeeth from Calgary, together with many other colleagues, is trying to do trials also in this population, or in pregnant populations, I should say, with a higher risk of thrombosis, the PARTUM trial, to see if it is feasible to do something that may be a little bit less effective, but in a larger group of women with aspirin, that is easier to do. And all these studies really need a lot of stamina. But as Hanke has already said, we have shown that it can be done. And I would really like to see lots of younger people starting up trials in this population. And in 10 years' time, or hopefully sooner, we will have newer answers. And I think that is something that we hope also that this study has led to.
That's great. Thank you both for this. I know Dr. Lena Castellucci was the one who recommended we speak with you, and she was quite excited about the fact that we were going to be interviewing you today. So I know there's a lot of interest in this study for across, as you said, across the country. And good luck with your PhD defense tomorrow, Dr. Wiegers. I'm sure it'll go just great. And I'm going to close by saying thank you to our listeners for listening to CLOT Conversations from Thrombosis Canada. We welcome your comments, questions, and suggestions on the podcast. And if you have any recommendations for future podcasts, please send them to us at info@thrombosiscanada.ca. Please subscribe to the podcast so that you're notified about the release of new episodes. And don't forget to check out our website for education programs, clinical tools, and guides. Also, we ask that you please consider donating to Thrombosis Canada to support our ongoing efforts to reduce morbidity and mortality due to thrombosis. And thank you, everybody.